Welcome to our educational video on the 2025 Guidelines for Acute Coronary Syndromes, developed by leading cardiovascular organizations. These guidelines are designed to enhance patient care with evidence-based strategies. Antiplatelet therapies are crucial in treating acute coronary syndromes. Dual therapy with aspirin and P2Y12 inhibitors like ticagrelor or prasugrel is recommended for 12 months, targeting platelet clumping to prevent blood clots. To mitigate bleeding risks, stomach protection medications are advised. Transitioning to a single medication like ticagrelor after the initial months can offer a safe alternative. Cholesterol management is paramount in these guidelines. High-intensity statin therapy is recommended for cholesterol reduction, with additional options like ezetimibe for further control of low-density lipoprotein cholesterol. Target levels below 70 mg per deciliter aim to reduce cardiovascular risk significantly. Invasive procedures for acute coronary syndromes have advanced, with percutaneous coronary intervention being a key intervention to unblock arteries. Accessing arteries through the radial approach in the wrist is preferred for its lower complication rates and quicker recovery. Complex cases may require additional interventions tailored to individual patient needs. These guidelines emphasize a comprehensive approach to acute coronary syndromes, focusing on optimal medication regimens, cholesterol management, and advanced procedures for improved patient outcomes. Stay tuned as we delve deeper into these essential updates for enhanced patient care.
Acute Coronary Syndromes Care. A report of the American College of Cardiology and American Heart Association Joint Committee on Clinical Practice Guidelines.
Hello and welcome. Today, we'll explore the 2025 Guidelines for Acute Coronary Syndromes. Discover the latest evidence-based strategies to enhance care and improve outcomes. Stay tuned, enjoy the highlights, and empower your clinical practice with this valuable and practical information for success.
Methods. A comprehensive literature search was conducted from July 2023 to April 2024. Clinical studies, systematic reviews and meta-analyses, and other evidence conducted on human participants were identified that were published in English from Medline, through PubMed, Embase, the Cochrane Library, Agency for Healthcare Research and Quality, and other selected databases relevant to this guideline. Structure. Many recommendations from previously published guidelines have been updated with new evidence, and new recommendations have been created when supported by published data. Evidence. Search of scientific acute coronary syndromes literature over past year. Recommendations revised per new evidence. Process. Professional Practice Committee. External peer review. Reviewed by the American Heart Association and American College of Cardiology Board of Directors. Standard of living. Funding. Funded out of the American Heart Association and American College of Cardiology general revenues. Does not use industry support. Table of Contents. Introduction. Overview of acute coronary syndromes. Initial evaluation and management of suspected acute coronary syndromes. Standard medical therapies for ST segment elevation myocardial infarction and non-ST segment elevation acute coronary syndromes. ST segment elevation myocardial infarction management. Reperfusion strategies. Non-ST segment elevation acute coronary syndromes. Routine invasive or selective invasive initial approach. Catheterization laboratory considerations in acute coronary syndromes. Management of cardiogenic shock. Complications of acute coronary syndromes. In-hospital issues in the management of acute coronary syndromes. Discharge, long-term management, and secondary prevention. Evidence gaps and future directions. Initial evaluation and management of suspected acute coronary syndromes. Initial assessment of suspected acute coronary syndromes. Pre-hospital assessment and management considerations for suspected acute coronary syndromes. Synopsis. Rapid and coordinated pre-hospital care plays a critical role in the optimal management of patients with suspected acute coronary syndromes. Patients with suspected acute coronary syndromes should be transported to the emergency department by emergency medical services. In contrast to transport by private vehicle, emergency medical services transport allows for assessment, monitoring, and treatment of potentially life-threatening conditions such as arrhythmias or cardiac arrest during transport to the emergency department. In patients with suspected acute coronary syndromes, trained pre-hospital personnel should obtain a focused history and physical examination, including assessment of vital signs, and obtain at least one 12-lead electrocardiogram so that the electrocardiographic findings can facilitate next steps in patient triage. Specifically, patients should be managed based on the presence or absence of ST segment elevation or suspected equivalent on the 12-lead electrocardiogram. When possible, electrocardiographic tracings can be transmitted to the primary percutaneous coronary intervention center while en route to help expedite coronary reperfusion upon arrival. Because patients with acute coronary syndromes and evidence of heart failure, ventricular arrhythmias, or cardiogenic shock in the pre-hospital setting are at highest risk for death, identification of these complications is important with subsequent triage of these patients to a percutaneous coronary intervention-capable facility when possible. Interpretation of Table 3.1.1 Pre-hospital assessment and management in suspected acute coronary syndrome. Section A. Suspected acute coronary syndrome. Objective: prompt identification of high-risk patients, particularly those with ST elevation myocardial infarction, using electrocardiography in the earliest phase of medical contact. 1. Electrocardiographic evaluation. Patients with suspected acute coronary syndrome should undergo a full 12-lead electrocardiogram within 10 minutes of their initial evaluation by a healthcare professional. Purpose: to rapidly identify candidates for urgent coronary intervention, that is, those with ST segment elevation myocardial infarction. 2. Serial electrocardiograms for non-diagnostic cases. When the first electrocardiogram does not confirm ST segment elevation myocardial infarction, repeated electrocardiograms should be obtained over time. This is especially critical when clinical suspicion remains high, symptoms persist, or the patient's condition worsens, as dynamic ischemic changes might evolve. Section B. Suspected ST elevation myocardial infarction. Objective: accelerate access to definitive therapy, primary percutaneous coronary intervention, by optimizing emergency medical services and hospital coordination. 3. Rapid transport to specialized center. For patients suspected of ST segment elevation myocardial infarction, the recommended strategy is urgent transport via emergency services to a hospital that performs emergency coronary angioplasty. System goals target a time frame of 90 minutes or less from the moment of first medical evaluation to the initial activation of the interventional device. 4. Advance hospital notification and team activation. Emergency medical personnel should notify the receiving hospital capable of performing emergency angioplasty as early as possible. This early alert allows the cardiac catheterization team to prepare before the patient arrives, thereby shortening the time to coronary reperfusion and improving outcomes. Clarifications. First medical contact. The initial interaction with a medical professional who can evaluate the patient, acquire and interpret an electrocardiogram, or perform life-saving interventions such as defibrillation. Primary percutaneous coronary intervention. A direct emergency coronary angioplasty, balloon or stent procedure, without prior fibrinolytic therapy, intended to quickly reopen blocked coronary arteries in patients with ST segment elevation myocardial infarction. Recommendation-specific supportive text. The early acquisition and recording of pre-hospital 12-lead electrocardiograms by trained personnel is associated with shorter reperfusion times and lower mortality rates from ST elevation myocardial infarction if this diagnostic information is integrated in patient's care. Appropriately trained emergency medical services personnel, that is, paramedics, can interpret 12-lead electrocardiograms for the identification of ST elevation myocardial infarction with high accuracy. When ST segment elevation or an equivalent finding is present on the initial electrocardiogram, initial management and triage should follow the prescribed ST elevation myocardial infarction treatment algorithm. Electrocardiographic changes are not required to confirm a diagnosis of non-ST segment elevation acute coronary syndromes. In patients for whom the initial electrocardiogram is non-diagnostic, Serial electrocardiograms should be performed during transport to the hospital, especially when clinical suspicion of acute coronary syndromes is high, ischemic symptoms are persistent, or the clinical condition deteriorates. Acquisition of subsequent electrocardiograms should not delay transport to a hospital. A second and/or third electrocardiogram during emergency medical services transport may identify up to 15% of additional ST elevation myocardial infarction cases not present on the first electrocardiogram. In an observational study of 728 patients with suspected acute coronary syndromes who underwent serial pre-hospital electrocardiograms, a ST elevation myocardial infarction diagnosis was subsequently made in 8% of patients following an initial non-diagnostic electrocardiogram with a median of 12 minutes after the first study. Posterior electrocardiogram leads, V7, V9, should be applied in patients with ongoing symptoms and a non-diagnostic electrocardiogram, and those with ST segment depressions in leads V1, V3 to assess for ST segment elevation in the posterior leads, which could indicate a posterior ST elevation myocardial infarction. Primary percutaneous coronary intervention is the preferred method of reperfusion for patients with ST elevation myocardial infarction. Rapid reperfusion of the infarct-related artery is associated with improved myocardial salvage and improved survival. For those who are managed by primary percutaneous coronary intervention, each 30 minutes of delay is associated with an increase in the relative risk of one-year mortality by 7.5%. As such, evidence supports system-level interventions to reduce time to device. Patients with pre-hospital identification of ST elevation myocardial infarction should preferentially be transported to a percutaneous coronary intervention-capable hospital with a goal of first medical contact. 2. First device time of number 90 minutes. For patients who are directly transported to the hospital by emergency medical services, the time to treatment goal is defined as the first medical contact by emergency medical services until coronary reperfusion. Direct transfer to a percutaneous coronary intervention-capable facility has been associated with shorter reperfusion times and lower mortality compared with transport to the closest non-percutaneous coronary intervention-capable hospital. In pre-hospital settings where a first medical contact, 2. First device goal of number 90 minutes is not feasible in patients with ST elevation myocardial infarction, direct transport to a percutaneous coronary intervention-capable hospital may be considered if the anticipated first medical contact to device time is number 120 minutes. The implementation of several care processes has demonstrated significant reductions in reperfusion times in patients with ST elevation myocardial infarction when implemented within a regional medical system. These include 1. Pre-hospital catheterization laboratory activation. 2. Single call transfer protocol for patients from a non-percutaneous coronary intervention facility. And 3. Emergency department bypass to transport patients directly to the catheterization laboratory for those presenting by emergency medical services to a percutaneous coronary intervention-capable hospital, and for transfers from other facilities. In particular, the pre-hospital activation of catheterization laboratories has been associated with lower short and long-term mortality in patients presenting with ST elevation myocardial infarction. Table 3.1.2 Initial in-hospital assessment of patients with confirmed or suspected acute coronary syndrome. Reference studies that support the following recommendations are summarized in the evidence table. 1. Electrocardiogram within 10 minutes. In patients with suspected acute coronary syndrome, acquisition and interpretation of an electrocardiogram within 10 minutes is recommended to help guide patient management. Class of recommendation: Class 1, strong recommendation. Level of evidence: Level C, limited data. 2. Serial electrocardiograms when initial 1 is non-diagnostic. In patients with suspected acute coronary syndrome in whom the initial electrocardiogram does not show clear findings, serial electrocardiograms should be performed to detect potential signs of restricted blood flow to the heart, ischemic changes, especially if there is high clinical suspicion for acute coronary syndrome, if symptoms persist, or if the patient's condition worsens. Class of recommendation: Class 1. Level of evidence: Level C, limited data. 3. Immediate cardiac biomarker testing. In patients with suspected acute coronary syndrome, blood levels of cardiac troponin should be measured as soon as possible, preferably using a highly sensitive cardiac troponin test. Class of recommendation, Class 1. Level of evidence. Level B, non-randomized data. 4. Timing for repeat troponin testing based on assay type. In patients with suspected acute coronary syndrome whose initial highly sensitive cardiac troponin or conventional cardiac troponin test result is not negative, the recommended time intervals for repeat measurements, starting from the first sample collection at time 0, are 1 to 2 hours for the highly sensitive assay and 3 to 6 hours for the conventional cardiac troponin assay. Class of recommendation, Class 1. Level of evidence. Level B, non-randomized data. Synopsis. Chest pain is the second most common presenting complaint to emergency departments in the United States and has a wide array of potential causes, including acute coronary syndromes. Although most patients with chest pain will not have an ultimate diagnosis of acute coronary syndromes, a missed acute coronary syndromes event has significant implications for the patient's morbidity and mortality. Patients presenting with signs or symptoms of acute coronary syndromes should undergo a history and physical examination, have timely electrocardiographic acquisition and interpretation, and assessment of cardiac troponin, because these tests are central to the diagnosis of myocardial infarction and will guide patient management. A thorough description of the evaluation of patients with suspected acute coronary syndromes is provided in the 2021 American Heart Association, American College of Cardiology, American Society of Echocardiography, American College of Chest Physicians, Society for Academic Emergency Medicine, Society of Cardiovascular Computed Tomography, and Society for Cardiovascular Magnetic Resonance Guideline for the evaluation and diagnosis of chest pain. Initial medical treatment should begin immediately for patients with presumed acute coronary syndromes. Urgent echocardiography, which may include an initial point-of-care ultrasound by trained clinicians, is indicated for patients with cardiogenic shock, hemodynamic instability, or for suspected mechanical complications. For patients with suspected ST elevation myocardial infarction, rapid reperfusion is critical after diagnosis. And further diagnostic testing should not delay cardiac catheterization or fibrinolytic therapy unless it would immediately change patient management. For patients who warrant additional testing to confirm a diagnosis of acute coronary syndromes, selection of the method of assessment may encompass several factors, including clinical history, electrocardiographic findings, cardiac biomarkers, patient preference, and patient exercise capacity. The use of evidence-based clinical decision pathways has been shown to improve outcomes and direct appropriate use of resources. Clinical decision pathways reduce unnecessary testing in 21% to 43% of patients while maintaining a high negative predictive value for major adverse cardiovascular events. Recommendation-specific supportive text. A focused history and rapid evaluation are critical in the assessment of a patient with suspected acute coronary syndromes. Early recognition and initiation of therapy for acute coronary syndromes improves outcomes. Rapid electrocardiographic acquisition and interpretation is required for identification of ST elevation myocardial infarction. In patients with non-ST elevation acute coronary syndromes, the electrocardiogram may be normal or demonstrate transient ST segment elevation, a high-risk finding, ST segment depression, T-wave inversions, or nonspecific changes. Of note, ST segment depression in the aneroseptal leads, V1, V3, could indicate an evolving posterior ST elevation myocardial infarction and therefore should be managed with a high index of suspicion with a posterior lead electrocardiogram if warranted. Overall, timely acquisition of an electrocardiogram is imperative in patients with a goal to obtain and interpret an electrocardiogram by a trained clinician within 10 minutes of presentation. An initial non-diagnostic 12-lead ECG does not rule out or exclude acute coronary syndromes. Electrocardiographic abnormalities may be dynamic. A non-diagnostic electrocardiogram should be compared to prior electrocardiograms, and a repeat electrocardiogram should be obtained during the emergency department course to assess for evolving changes. Right-sided leads should be obtained in patients with a concern for inferior ST elevation myocardial infarction to evaluate for right ventricular involvement. Assessment for posterior ST elevation myocardial infarction with an electrocardiogram is described in Table 3. The timing of repeat electrocardiograms should be guided by the patient's symptoms, especially recurrent chest pain, and any change in clinical condition. In National Cardiovascular Data Registry and Acute Coronary Treatment and Intervention Outcomes Network, 11% of patients ultimately diagnosed with ST elevation myocardial infarction had an initial electrocardiogram that was non-diagnostic, and 72.4% of those patients had a follow-up electrocardiogram diagnostic of ST elevation myocardial infarction within 90 minutes of their initial electrocardiogram. Cardiac troponin is the biomarker of choice for assessing patients for possible cardiac injury, with high-sensitivity cardiac troponin assays being preferred. Cardiac troponin is central to the diagnosis of acute myocardial infarction. Given its high sensitivity and specificity for myocardial injury, cardiac troponin, IRT, should be utilized to detect or exclude myocardial injury. In the setting of electrocardiographic evidence of ST elevation myocardial infarction, reperfusion therapy should not be delayed pending biomarker results. A cardiac troponin concentration 99th percentile upper reference limit, a value unique to each assay, is an indicator of myocardial injury. High-sensitivity cardiac troponin assays are preferred over conventional cardiac troponin assays because the sensitivity and negative predictive values of high-sensitivity cardiac troponin are greater. In addition, the time interval from chest pain onset to detection of high-sensitivity cardiac troponin is shorter with high-sensitivity cardiac troponin compared with conventional cardiac troponin assays, leading to more rapid rule-in or rule-out of ischemia. Acute myocardial infarction is characterized by a rising and/or falling pattern of cardiac troponin values with at least one value above the 99th percentile upper reference limit and believed caused by myocardial ischemia. With the development of high-sensitivity cardiac troponin assays enabling detection of circulating cardiac troponin at lower concentrations, clinical decision pathways using serial testing of high-sensitivity cardiac troponin at presentation 0 hours and 1 to 2 hours later provide high negative predictive value, as well as accelerated recognition of myocardial injury. Clinicians should be familiar with both the evidence-based clinical decision pathways and the analytical characteristics of the cardiac troponin assay, that is, limit of quantification, 99th percentile upper reference limit, and criteria for significant change used in their practice. Men and women may have different cutoff values with high-sensitivity cardiac troponin assays. With high-sensitivity cardiac troponin assays, changes in high-sensitivity cardiac troponin concentration within the normal reference range but below the 99th percentile upper reference limit can signal cardiac ischemia and may warrant further evaluation. Clinical decision pathways incorporating high-sensitivity cardiac troponin assays with repeat sampling at 1 or 2 hours from emergency department arrival with calculation of the change or delta. High-sensitivity cardiac troponin can identify patients at very low risk, exempli gratia, negative predictive value greater than 99.5% based on assay-specific diagnostic thresholds. However, when using conventional cardiac troponin assays, the sampling timeframe is extended to 3 to 6 hours from emergency department arrival. Cardiac troponin may be within normal range early after symptom onset, especially when a high-sensitivity assay is not used. When using a critical decision pathway that incorporates a single high-sensitivity cardiac troponin value, the troponin should be obtained at least 3 hours after the onset of symptoms. Figure 3. Initial assessment of patients with suspected acute coronary syndrome. Initial acute coronary syndrome evaluation flowchart summary. This figure outlines a structured, step-by-step approach for evaluating patients with symptoms suggestive of acute coronary syndrome. Exempli gratia, chest pain, shortness of breath, diaphoresis. Step 1. Initial evaluation. Take a focused history and perform physical examination. Obtain a 12-lead electrocardiogram within 10 minutes of first medical contact. Order cardiac troponins, CTN, or high-sensitivity cardiac troponin immediately. Step 2. Electrocardiogram results. If ST segment elevation is present in suspect ST elevation myocardial infarction, proceed to reperfusion strategy, exempli gratia, percutaneous coronary intervention, or fibrinolysis depending on availability and timing. If ST segment elevation is not present, then evaluate for non-ST elevation acute coronary syndrome. Continue monitoring with serial electrocardiograms and serial cardiac troponin measurements. Step 3. Use of critical decision pathways. These guide clinical decisions and risk stratification. Low risk may be suitable for early discharge after troponin and electrocardiogram exclusion of myocardial infarction. Intermediate risk, monitor with additional imaging, biomarker testing, and consider admission. High risk, consider invasive strategy, exempli GRACE, coronary angiography. Step 4. Medical therapy and risk management. Initiate therapies such as antiplatelets, anticoagulants, and anti-ischemic medications as indicated. Evaluate risk of mortality or recurrent ischemia to guide treatment escalation. This figure highlights the importance of timely electrocardiogram and troponin testing, early risk stratification, and structured decision-making to optimize outcomes in suspected acute coronary syndrome. Risk stratification tools for patients with ST elevation myocardial infarction and non-ST segment elevation acute coronary syndromes. Synopsis: substantial variability in short-term mortality and maintaining a high negative predictive value for major adverse cardiovascular events risk exists among patients with acute coronary syndrome. Individual risk assessment can inform discussions with patients and decisions regarding therapeutic interventions. Several risk scores have been developed and validated to help assess a patient's short and long-term risk in established acute coronary syndrome using commonly available clinical and laboratory variables. Although several risk scores exist, the Global Registry of Acute Coronary Events and Thrombolysis in Myocardial Infarction, risk scores for non-ST segment elevation acute coronary syndromes and ST elevation myocardial infarction, are well validated and may be useful for helping to guide some therapeutic decisions. These scores are not to be used as diagnostic tools because they stratify patient risk in the setting of suspected or confirmed acute coronary syndrome. Risk assessment using the Global Registry of Acute Coronary Events risk score has been found to be superior to subjective physician assessment for the prediction of death or myocardial infarction in patients with ST elevation myocardial infarction or intermediate risk non-ST segment elevation acute coronary syndromes. However, there is insufficient evidence that routine use of risk scores in patients hospitalized for ST elevation myocardial infarction, non-ST segment elevation acute coronary syndromes translates into reduced risk of cardiovascular events. Evidence of heart failure, such as pulmonary congestion detected by physical examination, chest X-ray, or lung ultrasound, is an important risk marker and integral part of the KILIP classifications, and thereby the Global Registry of Acute Coronary Events risk score and thrombolysis and myocardial infarction risk score for ST elevation myocardial infarction in patients with acute coronary syndrome. Similarly, elevated cardiac biomarkers provide prognostic information and also are key elements of the Global Registry of Acute Coronary Events and Thrombolysis in Myocardial Infarction risk scores. Higher cardiac troponin levels in patients with acute coronary syndrome are associated with an increased risk of death and maintaining a high negative predictive value for major adverse cardiovascular events, and similarly may be useful for helping to guide some treatment decisions. Several other serum or plasma biomarkers may provide additional prognostic information. In particular, natriuretic peptides, including B-type natriuretic peptide and N-terminal pro-B-type natriuretic peptide, may identify those patients with acute coronary syndrome at increased risk of death, heart failure, and recurrent, maintaining a high negative predictive value for major adverse cardiovascular events. Early recognition of cardiogenic shock in patients presenting with acute coronary syndrome on first medical contact by emergency medical services or emergency department providers is the key to initial triage and risk stratification. Cardiogenic shock related to acute myocardial infarction is present in 7% to 10% of the acute coronary syndrome population and carries a high mortality rate. Early and rapid revascularization for cardiogenic shock related to acute myocardial infarction is associated with increased survival. And triage to a percutaneous coronary intervention-capable hospital and ideally to hospitals providing advanced therapies, exempli GRACE, mechanical circulatory support, is preferred. Several scales are available to determine the severity of shock, and observational data have shown associations between severity as assessed by these scales and outcomes. Table 5. Selected risk stratification tools for patients with acute coronary syndromes. Global Registry of Acute Coronary Events Risk Score version 2.0. Target population: patients with acute coronary syndromes. Outcomes predicted: death or death combined with heart attack during hospitalization at 6 months, 1 year, or 3 years. Variables included: risk score calculated during hospitalization, patient age, KILIP classification, heart failure severity, systolic blood pressure, heart rate, electrocardiogram changes in the ST segment, cardiac arrest at hospital arrival, creatinine concentration in blood, elevated cardiac biomarkers such as troponin, thrombolysis and myocardial infarction risk score for unstable angina and non-ST segment elevation heart attack. Target population: patients with unstable angina or heart attack without ST segment elevation. Outcomes predicted: all-cause death, heart attack, or need for urgent coronary revascularization within 14 days. Variables included: age 65 years or older, 3 or more risk factors for coronary artery disease, such as smoking, diabetes, hypertension, known narrowing of coronary arteries 50% or greater, ST segment deviation of at least 0.5 millimeters on electrocardiogram, 2 or more episodes of chest pain within the last 24 hours, use of aspirin within the past 7 days, elevated cardiac biomarkers creatine kinase heart band or troponin, thrombolysis and myocardial infarction risk score for ST segment elevation heart attack. Target population: patients with heart attack with ST segment elevation. Outcomes predicted: death from any cause within 30 days. Variables included, with assigned points: age between 65 and 74 years, 2 points, or 75 years and older, 3 points. KILIP classification 2 through 4, 2 points. Systolic blood pressure less than 100 millimeters of mercury, 3 points. Heart rate over 100 beats per minute, 2 points. ST segment elevation in anterior leads or presence of left bundle branch block on electrocardiogram, 1 point. History of diabetes, high blood pressure, or angina, 1 point. Body weight less than 67 kilograms, 1 point. Time from symptom onset to treatment greater than 4 hours, 1 point. Table 3.2. Management of patients presenting with cardiac arrest. Reference studies supporting these recommendations are summarized in the corresponding evidence table. Recommendation 1. Class of recommendation: Class 1, strong recommendation. Level of evidence: Level C, limited data. Patients who experience cardiac arrest and are found to have ST segment elevation myocardial infarction and who have been successfully resuscitated should be transferred, preferably by emergency medical services, to a medical center that is capable of performing primary percutaneous coronary intervention. Recommendation 2. Class of recommendation: Class 1. Level of evidence: Level B, non-randomized studies. Patients who have been resuscitated after cardiac arrest and who are not in a coma or who are in a coma but show favorable prognostic signs and have evidence of ST segment elevation myocardial infarction should undergo percutaneous coronary intervention in order to improve survival. Recommendation 3. Class of recommendation: Class 2B, optional, may be considered. Level of evidence: Level C, limited data. In patients who remain comatose after cardiac arrest and present with unfavorable prognostic features but show evidence of ST segment elevation myocardial infarction, undergoing percutaneous coronary intervention may be reasonable following an individualized assessment. Recommendation 4. Class of recommendation: Class 3, no benefit demonstrated. Level of evidence: Level A, high-quality evidence. In patients who have been resuscitated and remain comatose following cardiac arrest, but are electrically and hemodynamically stable and do not have evidence of ST segment elevation myocardial infarction, immediate coronary angiography is not recommended, as it does not provide clinical benefit. Management of patients presenting with cardiac arrest. Synopsis: approximately 10% of patients with ST elevation myocardial infarction transferred by emergency medical services to the hospital are estimated to have an out-of-hospital cardiac arrest. Early recognition of ST elevation myocardial infarction in resuscitated patients and direct transfer to a percutaneous coronary intervention-capable center is associated with improved survival. Survival to hospital discharge in the patient who is comatose with out-of-hospital cardiac arrest is less than 10% regardless of etiology. Those with a witnessed arrest and a shockable rhythm have improved survival. Outcomes for patients with ST elevation myocardial infarction who are awake after resuscitated cardiac arrest are comparable to patients with ST elevation myocardial infarction who were not in cardiac arrest. For this reason, patients with cardiac arrest who have achieved return of spontaneous circulation and are awake with ST elevation myocardial infarction on electrocardiogram are candidates for primary percutaneous coronary intervention. However, care should be individualized in the comatose patient with rapid assessment of the patient's clinical features and cardiac arrest characteristics before proceeding with invasive angiography. In contrast, patients who are stable without ST segment elevation after out-of-hospital cardiac arrest do not require immediate coronary angiography. Coronary angiography can be deferred pending further risk stratification. Recommendation-specific supportive text. Observational studies have shown an association between triage of out-of-hospital cardiac arrest patients to a percutaneous coronary intervention-capable facility with improved outcomes. Data from the Cardiac Arrest Registry to Enhance Survival Registry showed that transfer to a percutaneous coronary intervention-capable center was associated with improved survival in patients with cardiac arrest and ST elevation, myocardial infarction on electrocardiogram. Emergency medical services should preferentially transfer patients who are comatose after cardiac arrest, have achieved return of spontaneous circulation, and have ST elevation myocardial infarction on the electrocardiogram to a primary percutaneous coronary intervention center. Although the arrest, advanced reperfusion strategies for patients with out-of-hospital cardiac arrest and refractory ventricular fibrillation trial did not show a benefit in triaging patients to primary cardiac arrest centers. This study evaluated patients without ST elevation myocardial infarction on the electrocardiogram. Nearly one-third of patients with cardiac arrest and ST elevation myocardial infarction on electrocardiogram have normal neurologic status on presentation to the emergency department. Being alert or with partial or minimal neurologic response on presentation with ST elevation myocardial infarction after cardiac arrest is an independent predictor of survival. Observational studies have demonstrated comparable survival of the awake patient with ST elevation myocardial infarction with cardiac arrest to those patients with ST elevation myocardial infarction without cardiac arrest. For this reason, patients with ST elevation myocardial infarction who have achieved return of spontaneous circulation and are awake should undergo primary percutaneous coronary intervention. In patients who are comatose after cardiac arrest and have achieved return of spontaneous circulation, but have ST elevation myocardial infarction on the electrocardiogram, an individualized patient assessment for survival and futility is essential before proceeding with percutaneous coronary intervention. Observational data have identified poor prognostic features that have been validated and incorporated into risk scores for this population. These include unwitnessed arrest, no bystander cardiopulmonary resuscitation, non-shockable rhythm, cardiopulmonary resuscitation greater than 30 minutes, time to return of spontaneous circulation greater than 30 minutes, arterial pH 7 millimoles per liter, age greater than 85 years, and end-stage renal disease on dialysis. Although these data suggest a lack of clear benefit for invasive therapies for patients with ST elevation myocardial infarction and cardiac arrest who have features indicating an unfavorable neurologic prognosis, this has not been validated in prospective trials. However, for those patients with favorable prognostic features, primary percutaneous coronary intervention is associated with greater survival. 6 contemporary trials have evaluated the role of emergency angiography in patients who remain comatose after cardiac arrest, do not have ST segment elevation on a 12-lead electrocardiogram, and are electrically and hemodynamically stable. These studies consistently demonstrated a lack of benefit to early angiography when compared with delayed or no angiography in the study population with comparable in-hospital and 6-month survival, as well as neurologic recovery. The relative utility of delayed coronary angiography in this population is uncertain. References. In conclusion, this initial section of the 2025 Guideline for the Management of Patients with Acute Coronary Syndromes has laid a solid foundation, presenting updated evidence, methodologies, and collaborative insights to improve clinical practice and patient outcomes. This guideline stands as an essential resource for healthcare providers committed to optimizing care for patients with acute coronary syndromes. Thank you for joining us in this video on Medicina Interna. If you found this content helpful, we encourage you to subscribe to the channel and share your thoughts in the comments. Your feedback is invaluable as we continue to grow and enhance the quality of our videos. Stay tuned for the next sections, where we'll dive deeper into acute coronary syndromes management and treatment strategies. See you in the next video. Let's keep learning together. Until next time.